Please join me in welcoming an outstanding physician leader and my longtime friend, Mark Williams.
Thank you. Well, although the only thing that these degrees mean is I have forgotten more than any person I know. So
make sure you're on that.
Everybody hear me okay? Okay, good. Great. Thank you very much. I'm going to present some information. Some of you have seen some of the information before. It's updated to attempt to talk about how health care and reform has moved along the last few years would literally take us days. So I'm just going to touch on some issues that maybe have some more timely relevance, especially with the upcoming elections next week. Give you a little background of where health care reform, where its genesis. Talk again about Medicaid expansion, which is as hot a topic now as it was several years ago. Talk about a growing phenomena, private health care exchanges, something that's certainly SMA has been involved or interested in providing health care insurance exchanges. Talk about where we are with accountable care, and a new term that's come into the language is clinically integrated networks. Talk a little bit about nurse practitioners and PAs, the challenges of new technology and pharmaceuticals, which interestingly enough dovetails very nicely with some of the comments made by speakers earlier this morning. And then lastly, maybe so much not a topic of formal healthcare reform, but let's talk about those things that really determine health. And the name health or healthcare is purposeful. They don't necessarily mean the same thing. So I think I had mentioned several years ago when I was with Alabama Power part-time, the University of Alabama School of Business sponsored a healthcare summit among the 100 large company CEOs in Alabama. And they invited these two individuals to come talk. Senator Frist opened up the meeting in the morning. Governor Bentley was the luncheon speaker. And of course the topic was healthcare reform and what did it mean to big business. And this is only, a little over 3 years ago. So here, Bill Frist, as you know, Bill Frist is one of the wealthiest individuals in Tennessee. He's Hospital Corporation of America, largest hospital corporation in the world. He's a primary owner of HCA, so he's a surgeon, hospital owner, Republican, former senator, and of course, we all know Robert Bentley is also a physician. And if it'd be interesting for you all to go back, if you have time. The whole dialogue with these two individuals is available on a website. But you can see, even then, the perception of healthcare reform was incredibly polarized. You had one person, Senator Frist, calling it 70% on target, we need to change 30%. You had another very respected individual, Robert Bentley, saying, boy, this is just the worst thing that ever happened. I dare say the polarization has increased even since then. So let's go back to, from a national standpoint, how people look at us when it comes to health care. And you all are familiar with the Commonwealth Fund, one of the largest philanthropic health care organizations in the world, released their most recent scorecard on how do we compare in terms of international health care systems. And people will pick apart parts of these things, but it's widely held out as a trusted resource. And the only thing that's different is they added some more countries from the prior survey in 2012, the Netherlands being one of them specifically. But here are the modern westernized countries of the world and comparing several dimensions of health care. 11 countries, and to the far right, the United States. And the United States, no matter which dimension you look at, doesn't compare favorably in this scheme. In fact, it comes in dead last in healthy lives, dead last in equity, dead last in efficiency, and last in timeliness or actually cost-related issues. It does well in providing effective care, timeliness of care. We've always heard, gee, you can get your services done here quicker than anywhere else. But even though it comes in sort of dragged at the end of the pack, it manages to do that at a cost twice any other country in terms of per capita expense on the population. So whether you believe all this or not, it certainly raises questions that continue today. So what have been some recent events in healthcare reform that have gotten the news media and all of us fired up. Well, this is one recent one. There's the Supreme Court decision on Burwell versus Hobby Lobby. Had to do with what can be offered in terms of contraception through an insurance policy, and it had to do with how does this affect closely held companies. And of course, the Supreme Court split pretty evenly. There was actually, they ruled in favor of Hobby Lobby, but of course it was split among the Supreme Court. And what people don't realize is that Obamacare and this provision of the law actually was taken word for word from the Institute of Medicine, which is a physician arm of the National Institutes of Health. Now, I don't know if many physicians knew, I'm not taking a position one way or another on this, but that wasn't by some government faceless body. That was from independent physicians. It was actually recommendation 5.5 by the IOM. So where are we in terms of how big a deal is healthcare reform in the political discussion today? What does it mean to the average person, especially with the elections coming up? Well, you can see that there are a lot of hot topics right now. The economy, education, our overall dissatisfaction with government at every level, the situation in Iraq and Syria, the Middle East. And pretty much, when you look at this little table, this is a survey done by the Kaiser Family Foundation, I think last month, October 14th, 2014. The healthcare law is important, but there are a lot of other issues that seem more important right now to the public. If you break that out among who proclaims to be either Democrat, Republican, or independent, you find that healthcare as an item of concern is 4th, 5th, and 4th. Again, the only relevance of this is how much energy is put into the rhetoric around this topic by politicians compared with what does it really mean to the average voter. If you look among Republicans or Democrats or independents in terms of do we want to repeal the law completely or do we want to simply try to revise it, again, it's all over the spectrum. One of the points I hope to leave with you today is that no matter what happens to the healthcare law, there are so many things happening right now in the infrastructure of healthcare driven by non-governmental parties that healthcare reform is taking place anyway. So, another case that's coming up that's going to be very interesting. It may not sound very interesting at this point because it has to do with whiteners, teeth whiteners. It's called the North Carolina Board of Dental Examiners versus Federal Trade Commission. It's been heard by the Supreme Court. No decision yet. But basically, what happened was companies were selling whitening agents and whitening products in malls, to the home, through the mail. And the North Carolina Board of Dental Examiners didn't like that. And they believed that these services and products, some of which they thought should lie within the province of be restricted to dentists. And of course, the challenge here is that 7 of the 9 members of the Board of Dental Examiners in North Carolina are practicing dentists, which raises conflict of interest issues, which is one of the issues that went before the Supreme Court. But the implications of this case and how the Supreme Court interprets the findings will be very relevant to every professional association board in the United States, possibly. Now, who's familiar with Ashley Furniture? Ashley Furniture has presence in 123 countries. Being in Tupelo the last few years, came to realize that much of the furniture sold by Ashley Furniture is manufactured in and around Tupelo. So one day I get this little email from an HR person in Mississippi. Hey, have you seen this? What is he talking about? So here is one page of the Ashley Employee Wellness Bulletin. You notice it has Satori World Medical at the top as a partner. This is a national publication. It has this new little program they're offering for anyone that needs any type of major surgery in 20 different specialties. The program is paid 100% by Ashley Furniture, includes all your hospital and physician costs, you and your companion's flight, a stay at a luxurious 4-star hotel, no deductible, $5,000 paid directly to you from company, $500 spending money from Satori, no bills, no hassle, no medical costs. This is the Deep South. This is Mississippi, where we're seeing this international medical tourism product being offered. Hospitals, where are you going to get these services? Well, there are hospitals that have leading edge technology, and they're actually managed and possibly in many cases owned by Johns Hopkins, Harvard, Columbia. All their surgeons have board certification. They're all English speaking. And by the way, every one of those folks who may operate on is available by phone or video for consultation before you make the decision to go. And if you bring your companion, you'll stay at a luxurious 4-star hotel, hotel, flight, ground transportation, 24/7 customer service. And your case manager will coordinate all of your care, transfer your medical records, schedule your procedure, and help with follow-up appointment with a U.S. physician addressing the need of what do I do if something goes wrong. And that's pretty remarkable. Why in the world would they spend all this money doing this? Because they must think they're getting a better product. Where are you going to go? You're going to go to Costa Rica, India, Mexico, the Philippines, Puerto Rico, Singapore, Thailand, Turkey. Again, I'm not discussing the merits of the program. All I'm saying is this is what's out there. This is what we're competing with, and you all feel free to check it out. There's the website. It's no secret. So why are they doing this? Well, maybe this is one reason, because now health insurance, the total cost for health insurance for a family now is equivalent to the total cost of a year of in-state tuition at a local college. And it's now equivalent or exceeds the family's average annual home mortgage cost. If you look at where healthcare costs are going, we had this a little bit reassuring period that began with the recession in 2008, when healthcare costs were not clipping along at 3 times the consumer price index. So indeed, many healthcare costs actually eased a little bit, and some people took a lot of reassurances that maybe we could hold this trend. But some of you heard this morning about the new age of targeted therapies and drugs. You've heard about genomics and personalized medicine. That's expected to, again, accelerate the cost of health care back into the 7.5% to 10% annual increase in cost. And of course, what people in the United States are really trying to do is they're not really trying to lower the cost of health care. I think most of us are saying we can live with 17 to 18% that it represents of our GDP, and we don't mind if prices go up. But they have to go up with the general economy. They can't occupy 22% of our GDP within 20 years. And what I'm hearing from employers is this issue. You know, even though all of my employees and their dependents have health insurance, there's only that 1% that's really driving our cost. That's what we need to go after. We need people to coordinate the care of these people that have 2 chronic conditions. 45% of Alabama Power employees over the age of 50 have 2 chronic conditions at least. And these complex Medicare patients that cost on average $90,000 a year. 95% of our patients only absorb 5% of our total health care cost. And that portion of patients that absorbs more health care cost is growing dramatically. You all know the baby boomer trajectory. You know the trajectory well, but what a lot of people don't really appreciate is this new piece, this prescription drug piece, that is alarming employers. We'll talk some more about that in a minute. That's sort of a new piece. And this is what I was talking about. If the trajectory continues in terms of our national budget, by 2040, on Medicare alone, not total health care costs, on Medicare alone, it could be 20% of our total budget. This debate has not calmed down at all. We've already mentioned that Obamacare is perceived as more expensive, more subsidized, certainly more complex. I don't disagree with any of those things, but it is creating a sensitivity to price, which that part will not go away. Moving a little bit to Medicaid expansion, very important to us in the South because it's pretty much the South and the red states that did not want to pursue Medicaid expansion under Obamacare. They still have to cover many of their citizens. The governors are still looking for ways to provide coverage, and because they're getting a lot of pressure from hospitals and physician organizations and those who have to provide the care anyway. So let's talk a little bit about what states who did not opt for Medicaid expansion on Obamacare, what are they doing? And I've been on the Mississippi Medicaid redesign team for the last year and a half. Somewhat familiar with we'll skip that, somewhat familiar with the issues. So I'm going to present some Mississippi data. And again, this points to sort of sometimes the gap in knowledge that we all have when it comes to how we spend healthcare dollars. So here's, when we say we don't want federal money in the South or in any other state for Medicaid, in Mississippi, 74% of all the money that the state spends to take care of Medicaid patients is already coming from the federal government. That's the degree of match. And it's broken down a little further here in terms of state funds. So the 26% that comes from states comes from general funds, provider taxes, and other sources. And you can see that you're talking about almost $6 billion. In Alabama, it's a little more. On U.S., on average, for every state government providing Medicaid, that's what the federal government provides. And of course, the federal government's often giving you money back. I'm not saying that's just this large yes of the federal government. But the bottom line is we couldn't survive without federal support for Medicaid. So in Mississippi, when you say, okay, we got this money going out for Medicaid, how does it affect the other important items in our state of Mississippi? As we devote more resources to Medicaid and we live under a fixed state budget, so Medicaid is over here around, and it's in the social welfare piece, and this is Mississippi, a state burdened by a lot of chronic disease. When we spend more money on health care, by necessity, we're unable to spend money in other important areas, schools, roads. So what we do in medicine, in healthcare, and spending dollars often affects teachers and other people who have little voice in how we spend healthcare dollars. We talk about what do Medicaid patients, what kind of patients are we taking care of in the Medicaid program? Well, we see the same thing reflected on a national basis. A quarter of the Medicaid patients account for 64% of the cost. Again, it's that chronic disease piece, the piece badly in need of case management where all of our costs are. You've seen this kind of debate in a lot of our southern states. This is a state that, it was not a southern state, but it was Ohio. The governor finally said, I've got to give in to Medicaid expansion. And so he is one of the few states that sort of changed his mind. He was pressured by the business community and the provider community. But let's look at what a state is doing that said, I just reject Obamacare and Medicaid expansion, but I still want to try to cover our citizens. And this will be very similar in some other states. This is what Mississippi is following this model as well. So a Section 1115 demonstration proposal is an opportunity under Obamacare for a state to seek an alternative model, as long as it's budget neutral, to provide this type of coverage for its citizens. It's supposedly saying if a state has a better idea, let's give the state the opportunity to do it. It's called a Section 1115 waiver. So in Alabama, if you Google 115 demonstration proposal Alabama, and you come up to the preamble of the purpose of that legislation, this is word for word from that preamble. We want a delivery system that is risk-bearing, that has the full scope of benefits, that coordinates care, has a medical home, that transitions from volume-based fee-for-service to a capitated model, and the transition from a hospital-based payment system to providers to reform care delivery. This is not from the Obamacare literature. This is from Governor Bentley and his staff. Capitation, value-based services, Clinically integrated networks, medical home. Medicaid population in Alabama is about 654,000. In Mississippi, it's nearly 800,000 people. Switching gears a little bit more to tie together the government health care exchange with what's happening with private exchanges. So a lot of fanfare, a lot of criticism, a lot of failure as the government introduced its health care exchanges. In those states that adopted it, kind of put a lot of energy into it, they had less issues than those who rejected it. That was just like any program would be. But what about this whole exchange concept, buying insurance on an exchange? Well, some of you remember this slide from before. It's not a new idea. In fact, it's an idea that's been around for 20 years. I was a member of the Eagle Forum. I was a member of the Heritage Foundation. I was a supporter of the Bushes. I was an early proponent of medical savings accounts because I thought this was a great idea. So here's the Eagle Forum in their newsletter of June 1996 talking about the problems with health care and what would be an ideal solution. Well, the system of having your employer own your insurance policy they felt was bad. You lose your job, you lose your coverage. The correct solution was to move toward a system in which individuals own their own health insurance, thereby their mobility from school to job would not be impeded by concerns on health insurance, and that individuals should get the same tax treatment as a corporation. In other words, I should be able to deduct that from my gross income and enjoy the tax deductibility part, which for most of us in this room is a 35% discount on the product. Well, with that in the background, this was some interesting headlines about a year ago. And it referenced, if you can see the small print, Obama is killing traditional employer-sponsored health care, Obamacare. And it says IBM, Walgreens, add to that Sears and Walmart, and a lot of other companies, they were doing something different. In fact, they were adopting this model. So Walgreens switches to defined contribution and private exchange model. So Walgreens has 160,000 employees, and they said, you know, some of you are married, some of you are single, some of you have no kids, some of you have 1, 2, 3 kids. Can we really find an insurance product that works for all of you all, or are we simply trying to find the same size shoe that fits really nobody? They also had a concern that, you know, my health care cost as a Walgreens employer is going up 10% a year. These employees are the ones that are in a position to help control their own health care costs. Let's put some skin in the game for them. So from a business standpoint, being able to predict next year's cost, just like we do with any budget item, Walgreens said to their employers, listen, to their employees, we want you to have insurance. I mean, a good company wanting to attract good employees is always going to offer insurance. But they said, it can't be a black hole, and you've got to have skin in the game. So what we're going to do is we're going to pay you, just like we do in retirement now, 401k, for example. We're going to pay you a certain amount of money that covers the cost of a policy, and you go out and pick it, and you own it. And what we'll do as a company, we'll supply the exchange and all the information for you to choose. And that's what IBM has done, Walgreens has done, Sears has done, a lot of big companies have done. But you can see which side you're on. On one side, that change is characterized as killing insurance. On the other side, it's seen as advancing insurance policy for employees. So what about these private health care exchanges? They're growing very fast. In fact, 18% of the American public will purchase insurance through exchanges according to Accenture, which is a business consulting organization, within a few years. Enter the next problem in this whole health care reform discussion. These are sophisticated topics. I've had to work hard to try to understand them. The general public has very little understanding of any of what we're talking about. And how can we ever get a good policy, social policy, when those people that are affected by all these things have no idea of what we're talking about? In fact, if you ask them specific questions, have you ever heard of the new health insurance marketplace? When you have every age group, insured and uninsured, with at least 50% of them saying no, how can you expect to have informed, good decision making? If you ask them if you're aware of some of the consumer protections in the new Obamacare or Patient Protection Affordable Care Act, such as keeping your kids on there till they're 26, it doesn't make any difference if you're a Republican, Independent, or Democrat. Most people don't know what these things are. Some of you may have been watching Jay Leno before he went off, and he's walking around the streets, you know, asking people questions, you know, like when was the War of 1812? He asked these folks, which plan do you support? Obamacare or the Affordable Care Act? Woman number one, the Affordable Care Act. Well, what is it about Obamacare that you do not like? I just think that there's a lot of holes in it, and it needs to be revamped. I think it hasn't been thought out, which she's absolutely right, but she favors the Affordable Care Act. Hence, a perilous gap in health insurance literacy. 9 in 10, coming up this month, very shortly, the re-enrollment period for the public exchanges. For every 10 people that are eligible for re-enrollment or initial enrollment, 9 don't even know when the dates are, what it means. Is this an opportunity for us as a profession to provide information that maybe not is so tainted and emotion-driven? I think so. So we talked about Walgreens a little bit. We won't talk about that anymore. Okay, when we go to these, when a Walgreens employee now goes to this exchange and has all these products to choose from, they're probably going to discover something else. If I choose this plan because it's less expensive and I download the PDF and I find a list of the providers, I may discover that all the providers that I previously had access to, they're not on there. Hence, the discovery that we now have narrow networks is what we're calling them. And initially, again, many people said, I want access to everybody. But when you start putting a price on that access to everything and people say, you know, that makes $100 difference to me in my monthly premium, all of a sudden consumer direction can shift. Patients, it turns out, are very price sensitive in their decisions to switch to limited network plans. And of course, those that have no health care problems are the ones most likely to accept the narrow network. The exchanges, when we talked about Walgreens, or we talked about the Alabama Federal Exchange or the Mississippi Federal Exchange, there was some concern initially that choices were going to be limited. In Mississippi, as a matter of fact, there were only 2 initially, and if you lived in certain counties, there really wasn't any choice. So this came out last week talking about new competitors on the exchanges. And it turns out that if you've been following the news with Aetna and United and all the major healthcare providers and all the major hospital players, HCA, Tenet, CHS, all their profits are up. They were doing really well these days. And what it turns out is that 57, across 41 states, 57 new insurance companies have entered those exchanges. If you were in Alabama anywhere on that last weekend, the Sunday paper on the front page to the top left, premiums kept low in state due to competition. United Healthcare enters the Alabama marketplace. And for those of you who knew much about Alabama, why is that a big deal? It's because Alabama Blue Cross is held out as the most dominant Blue Cross in the United States with 90+% of the commercial market. If you say, well, give me some idea of how premiums are really changing across the country as a result of these exchanges and these choices. And again, you can make a case for they're going up or they're going down depending on where you live. It requires, again, considerable research and knowledge which our population really doesn't possess. Here's the thing on Aetna. They're doing so well by going to so many exchanges, they're revising their revenues upward. So employer health care costs continue to grow at an unsustainable rate. That hasn't really panned out. Employers are paying more for the Affordable Care Act. There's a little misprint here. Evidence continues to mount that value-based health care delivers better value than fee-for-service. Like I said, it's a misprint. And we talked about 40 million people going into the health exchange in a few years. All right, so before I left Mississippi, I had an opportunity to meet with a really nice bunch of folks called the Mississippi Business Group on Health. And, of course, we were meeting with them as part of a clinically integrated network of the 9 largest healthcare systems in Mississippi wanting to take business away from Blue Cross and go directly to employers and also take over the Medicaid business. Say, well, we thought they would want to talk about hospital rates and ER visits, those things that we traditionally seem to drive healthcare costs, and they were interested in those things. But they were really interested in wellness and changing the behaviors of their employees. And they brought a pretty sophisticated background in this. And if you ask Billy Sims, who's president of that coalition and vice president of HR at Southern Farm Bureau, he's not a big supporter of Obamacare. But what he said is, like we heard earlier, it has certainly caused people and companies to be more conscious of the needs and to get together and look at possible solutions. Access to health care accounts for only 10% of overall health outcomes. It's hard to overstate the importance of people living healthier lifestyles. Again, that's Billy Sims talking. So when we're going as a group of hospitals in front of the Mississippi Business Group, we are in effect going as a quasi-accountable care organization. And how are they doing? Well, maybe more than the insurance exchanges, the ACO movement is not slowing down. It's growing very fast. The ones that are physician-driven and non-Medicare are growing the fastest. And by the way, a Medicare ACO does not require the participation of a hospital. So you don't have to believe your hospital administrators when they tell you, you have to have us to have an ACO. In fact, the highest performing ACOs that return shared savings to their physicians are driven by doctors. Right now, more than half of the population could already receive their care in ACO. That's the ACO capacity that's already there. Last week, Aetna alone announced 4 new ACOs. The entire medical system for Cornell, the entire system for Baylor, Scott & White, and 1 more. So no, they're very large players. This week's New England Journal reported for the very first time Medicare patients' experiences in accountable care organizations. Now let's go back to who needs the care that needs to be coordinated. It's that 10 to 20% of our population that has multiple issues. Among patients with multiple chronic conditions and high predicted Medicare spending, overall ratings of care differentially improved in the ACO group compared to the control group. Probably doesn't really come to us as a surprise to us that coordinated care for people with multiple conditions produces a better outcome. In that article, they also discuss that we don't know if ACOs are going to be successful or not. And they could be successful for the wrong reason. There's a risk of failure of ACOs because organizations like your offices are having a hard time taking that step from a fee-for-service environment to a value-based payment environment. How do we pay the bills during this time? And what does it mean to me? We don't know what the return on the investment when we invest in the IT infrastructure that an ACO needs and all these things. How are we going to get that money back? We don't know. And by the way, the government wants us to do this now. This is going to take years to get it right. An experience we probably learned from the electronic health record debacle, as some might call it. They also said there's a risk of success of ACOs if they're successful for the wrong reason. If they're successful because they're all getting together to have more leverage to generate higher payments and higher fees, That's not going to help any of us. It would be helpful if more doctors step up to the plate, this is the last sentence in that article, and take an active role in organizing and governing ACOs, a role that CMS and health insurers encourage. Talk about nurse practitioners and mid-levels for just a second. I think I've shared this slide with you maybe last year. Nurse practitioners, especially in family practice, and PAs, are of course in great demand. And I think it was mentioned during some of the talks earlier, we've had an explosion of medical schools, especially DOs. You're seeing the same explosion in the training of mid-level providers. In fact, growing is faster than physicians. If you're an organization and you say, why would I hire a nurse practitioner to maybe take care of the patients who aren't quite so sick in my ER, which most ERs are doing, it's not a hard thing to understand, because this is sort of, if you sort of take it as a difference in terms of compensation just very broadly among these different professions, it makes it very easy to understand why a cardiologist's office may hire 2 NPs to do patient education, manage medications, because they can't hire a cardiologist to do it, nor would it make sense. If you ask patients, say, would you rather see a doctor or would you rather see a nurse practitioner? Every one of them will say, I'd rather see a doctor. If you ask them, you can see a doctor today, or you can see a doctor 2 weeks from now, or a nurse practitioner today, many of the answers change. Now let's talk about technology just a little bit and how it plays in terms of healthcare reform and going forward. And we heard a little bit about that this morning. We know that part of our costs are going up because people are getting older, but our costs are going up to a greater degree because we're embracing more technology. And unlike every other industry in the United States, when we get improved technology, it doesn't lower cost, it increases our cost. I mean, any of us that work in hospitals, and I've had my foot in hospitals and clinical practice now for 30-something years, the cost of some of these things is simply mind-boggling. Pacemaker, $50,000. Gee, the company convinced you need a new upgrade for the software for the machine. That's on a cool $1 million. And by the way, I have to have it because the hospital down the street has it. So this is Massachusetts Institute of Technology a few weeks ago, the paradox of healthcare technology. Why is it that innovation always increases the cost of care? So let's talk about some of this innovation, and some of my slide formats may have changed. We changed it to a different version. But in 1970, how many people needed bypass surgery? The answer would be almost 0. If you said, but a few years later, we're doing $400,000 a year at the average cost of $124,000 each. Very shortly after that, we're doing a 1.3 million coronary angioplasties, putting in 120,000 ICDs. I have a friend of mine, Dr. Boudreau, who's chief of staff at UAB. He and I were talking about ICDs, and we were talking about it in the context of the OIG investigation that was going across the country about how many ICDs we're putting in people. And he joked, but he wasn't joking. He said, Mark, everybody in our entire dinner party group has an ICD in place. And ICDs are truly life-saving devices that represent great advances in technology. But they also pay a lot when you put them in. We are just now talking about left ventricular assist devices, and we move up into the next era of life-saving cardiac care. We're talking about the devices and procedures that will be $300,000. Can we afford all this? And that's just cardiology. So it's interesting when you look at all these things that increase life, they now expose us to more diseases. If we're going to live longer, we're going to die now from something we might not have died from before. So we're going to go a little bit about the discussion this morning about targeted drugs. Now this is really not so much part of healthcare reform, but it's an issue that's going to face all of us very soon. So here's a nice Time magazine cover, and they found another magic bullet that's going to cure something. A few years before this, they had a cover for a magic medicine called Fen-Phen that was going to cure obesity. So here's the magic bullet that's going to cure cancer. And one of the earliest examples of that was a remarkable drug called imatinib, tyrosine kinase inhibitor. It turned basically a deadly cancer into a chronic disease. And the original researchers were honored for converting a fatal cancer into a manageable chronic condition. That is all great. Sounds good. If I had that disease, that would be very good for me. It was invented by Ciba Geigy and originally sold for $30,000 a year. Now, this is annual now. This is a chronic disease. Then it was bought by Novartis, and price went up 3 times for no obvious reason. Other than, like our speaker this morning said, we had a captive population. I don't know if any of you all have heard of Glivec, but here's another drug that came out at $100,000 cost. And if you look at the National Cancer Institute newsletter, a recent article, a recent 2009, talking about the cost of some of these drugs, you're starting to say, how much does someone pay for 3 extra months? Or if you widen the confidence intervals, maybe it's only 2 or 3 weeks in terms of survival. If you take this drug alone, which gave you 4 weeks estimated longer survival, you are effectively placing a cost, an annual cost in terms of extra year of life gain of $800,000. There's now books been written about this industry. The billion-dollar molecule. Let's find the next billion-dollar drug and get very wealthy. A high-stakes tale of adventure and intrigue, barbarians at the lab. It sounds like the great merger and acquisition events of the 1980s. Only it means something to patients and doctors who treat these people. So here is the chair of leukemia division at MD Anderson taking a stand. The price of drugs for CML, a reflection of the unsustainable prices of cancer drugs from the perspective of a large group of CML experts. As Dr. Canturon says, they do not reflect the cost of development, like we heard earlier. In many cases, they reflect the fact that someone can make exorbitant products because they have a captive population that really has no other choices. Are all drugs manufacturers that way? Certainly not. But it's becoming a big issue. Remember, the Mississippi State Business Professionals, that little group, their major issue was this. So if you look at it from an economic standpoint, gee, is that how we really want to spend our money? We don't want to deprive people of life-saving drugs. All of us would embrace that sentiment. But we have to be rational about it at some point. All right, so why would an economically rational society not make these more reasonable reallocations of healthcare resources? So who are we going to let make these decisions? It needs to be people like you. One other drug which really tugs at your heart, cystic fibrosis. The first medicine to treat the underlying cause of CF. 30,000 CF patients in the United States, 1,200 of them with this specific genetic benefit which this drug can treat. $300,000 a year for treatment. So here you have Arkansas Medicaid director saying, if I do this, I can't supply services to thousands of other patients. Very hard choices. Arkansas stiff arms the patients. And again, you can paint this rhetoric in any emotional tone, but it's a reality. So how do we sort through some of this? Is this just dismal or is there hope? We heard a little bit about Watson at this session. You heard about Watson being at Sloan Kettering. They're also at the Mayo Clinic. Often when we're providing these drugs, especially in the world of hematology, oncology, as many hemonc doctors have told me, Mark, I want to be an advocate for that patient, and I want to give them every hope And as doctors, we frequently overstate the favorable outcomes and we understate the negative outcomes. These doctors are well-meaning, their intention, they're doing what they were trained to do. They don't have the information they need for them and their patients. That's the opportunity of something like this type of tool. Not to take the place of a physician, but to help make better choices. Going back a little bit in history, again, how physicians treat themselves when it comes to some of these issues. Now this is quite a few years ago. It sort of ignited my interest in patient safety because this Time article was saying doctors don't want to be in hospitals because they already knew how dangerous hospitals were, but patients didn't. This article came out a couple years ago in the Wall Street Journal. Now it related to end-of-life treatment. What do I want from me as a physician who presumably has some knowledge of the benefits and risk of these treatments and cost? It was really interesting in that article. Another article was referenced in that doctors in this particular group, 2/3 of them had advanced directives that said, I don't want these things. And at that time, only 20% of the general public had these things, which ought to tell you something. And what it says is, boy, these are going to be hard choices, but we don't want government to make them. We want you all to make them. This is our opportunity in terms of organized medicine and coming together and understanding the realities that I think gives us an opportunity to make a difference. I just skip over a couple of these things. The title of my talk was Health versus Health Care. They're not the same thing. So everybody remembers Kodak, right? How many of y'all had a Nikon camera at some point, some really nice camera? You love taking pictures. And for me, I always loved taking pictures, and my wife would make fun of me. I'd go on a trip and bring back 25 rolls of film. We'd drop it off at Wolf Camera and pick it up a few weeks later, just wait to see. I didn't really want the camera, and I didn't really want the film. What I wanted was the image, right? Right? Well, Kodak forgot that part. They ignored the emergence of digital photography, and as digital photography use went up, the stock price of Kodak went exactly down and out of business. They didn't know people wanted images, not cameras and film. Same thing true of some of the great railroads in U.S. history. People didn't want to get to point A to point B on a railroad necessarily, on a rail car. They wanted to get from point A to point B in the most efficient fashion. So when the interstates opened up and other modes of transportation, many of these railroads just sort of missed the boat. Is that what's going to happen to us in healthcare as we focus on rescue care and not that people really want health? Which brings us to sort of the wrap-up of my talk. Again, going back to what employers are now talking about. Yeah, they're interested in hospitalizations and ER visits. What they're interested in is this, the social determinants of healthcare. And our SMA Alliance actually promotes these things, right? They know the value of social and community context, education, the neighborhood, economic stability. And us as physicians, we need to find a way that we can demonstrate this value and make a living out of it. So what really makes the difference? This is my daughter and our brand new grandchild who's now 7 months of age. This is, I'm visiting them in Montana, and she's at that point 4 months. I'm trying to bring her up on a Mac and avoid this Windows world. And as I've observed, this is a new experience for my wife Sandy and I, as I've observed over the last few months, this incredible development. It just blows your mind because my wife and I see this in snapshots. You're thinking, my gosh, my grandchild's going to do well. And you're saying, man, she's going to have advantages that kids not born into such fortunate circumstances will not. So what could we do? What is a simple thing that we can do as a SMA, as a physician, to really help people live healthier lives? Now, I'm going to borrow this information from George Howerson, CEO of the Kaiser Clinic, in a presentation that he made. What's the best predictor of who will drop out of school, get pregnant, or be in jail by age 18? realizing that Alabama, Mississippi, Louisiana, and Texas spend huge amounts to incarcerate people each year. 1 out of 200 individuals in the state of Alabama is in a prison. These are the 2 best predictors: vocabulary in kindergarten, reading skills in the 3rd grade. Remember back when I was saying what we spend in health care can take away from education? We may be actually self-defeating ourselves by spending more on health care. So lacking reading skills in 3rd grade directly correlates to 40% more likely to be pregnant at a young age, 60% more likely to drop out, 80% more likely to be in jail. Here are the 2 resources for either one of those. In that 2nd book, he has a specific number that is just mind-boggling to me as to why we cannot accomplish this. And this is not necessarily a doctor thing, a physician thing, it's a society thing. Total picture book reading time hours per child by 1st grade. I observe what my new grandchild is being offered every single day for hours. Stimulation, movement, new places, books. A low-income baby born in Medicaid gets an average of 25 hours of someone reading to them by the time they get to 1st grade, versus a middle-income child of 1,700 hours. This does not seem to be an insurmountable problem, understanding the potential benefit that we could all enjoy. 1,000 hours could be transformational. Last couple slides. I read this book a few weeks ago. It was very disheartening. It was called Disillusionment of an American Physician. What got my attention was his comment that if a doctor doesn't do excess testing, he isn't going to be able to live. Those of you who know me very well know that one of the things that drove me into this patient safety movement was one of my very best friends died from a medical error after having a TAH and a BSNO based on a false positive CA125. So when I see this, I'm thinking, why is this person in healthcare? He says it's a sign of our dysfunctional health system. Yes, it may be a dysfunctional health system, but there is never any reason for a doctor to take that sort of position. He needs to change it. Talk about the disillusionment of American health care. We all deal with this. Despite that, some of you may have heard 3 days ago when the American Association of Medical Colleges announced the 2014 medical school enrollment figures. They're now bumping 50,000. The challenge in medical education is that now exceeds the number of graduate medical education spots available. We have record construction of medical schools and record enrollment. People want to be physicians. So, the last slide, if you want to read something by an author who is consistently upbeat and providing a vision for all of us, Dr. Gawande. You may know Dr. Gawande. He's a distinguished surgeon at the Brigham. He gave the commencement address at Harvard Medical School 2 years ago. He's written 5 books. For those of you in the surgical world, he's the one that built the Checklist Manifesto. He describes his experiences mostly with his father, who was a urologist who developed a spinal tumor. He talks about end-of-life issues. And it's very interesting. He talked about 3 types of physician-patient relationships. The first one that most people believe is traditional is the paternalistic perspective. I'm the doctor. I know I have the knowledge. I'll tell you what to do. And Dr. Gawande encountered all 3 of these at the Cleveland Clinic and in Boston. The second one was the informative doctor. I'm going to give you a whole lot of options. I'm just going to lay it out for you. I'm going to be transparent, but I'm not really going to help you make a choice because that's your responsibility. What I read in this book and what was so appealing to me was the value of that physician interaction was to take the information at hand, the best information, and to help guide that patient through the right choices and to understand what that patient really wanted. So if you have time, pick up the book. It's a great book. It's been out a couple months. So thank you very much. Healthcare is very complicated. We're going to be dealing with these issues for a while, but there's no shortage of challenges and no better time for us to step up to the plate. So thank you very much.
Thank you, Mark. That's just excellent and quite insightful. Do we have any questions for Dr. Williams? As if that didn't open up just a can of worms between his talk and our Watson talk yesterday. Go ahead.
Yes, sir.
There's a suspicion been going around that the Affordable Care Act is simply the initial salvo over the bow towards a single-payer system. What are your thoughts about that?
Well, I think there are clearly, the question is the Obamacare represent the first movement toward promoting a single-payer model? And I think there's an awful lot of people that, even those who may have constructed the bill, that feel that way. So yes, I think there is some people that feel that way. But what I've attempted to show here, in reality, what's happening is there's, in many ways, more innovation taking place in healthcare and more movement to private insurers than there has ever been. So there are a lot of people that favor a single payer. In Alabama, we effectively have a single payer. If you're under the age of 65, it's Blue Cross. If you're over the age of 65, it's Medicare. So I don't think that's where we're going to end up. I think we're going to end up with where the Eagle Forum projected we might end up back in 1996. We're going to have exchanges with a lot of private insurers, ACOs, narrow networks, and we'll have more choice as individuals. When we reach 65, we're going to face a Medicare that's going to have more restrictions because we can't afford the cost, and there'll be supplemental insurers to come in and fill that gap.
A lot of the states that did not accept federal money for their Medicaid programs are moving patients, like in Florida, onto managed care health management organizations. Is that really the answer to our problem?
No, sir, I don't. In the Mississippi experience, and Dr. Jim Rich back here could probably speak to some of it. So the Mississippi Hospital Association promotes that perspective to move to a managed care model. Mississippi Medical Association, I don't want to misspeak, believes that there is better models. So the answer to is I don't favor a managed care model. I favor a model that's put together by physicians working together in networks. And when we talked about networks, clinically integrated networks of physicians, that does not imply employment. Private doctors can be part of clinically integrated networks as well as an employed physician. What a clinically integrated network does imply, however, is that we agree on a common set of values and we have a good infrastructure that's fair to distribute compensation, monies. That's what a clinically integrated network means. I hope I answered your question. I will say, in terms of single payers, of those 11 countries that you saw in the Commonwealth chart, performance of the U.S., a lot of people say, why is the U.S. so different? It's because 10 of those 11 have single payer networks. Yes.
I saw recent numbers of 930,000 physicians in the United States. 214,000 have opted out of Obamacare. Problem number one. Problem number two is we're hearing that even though people have the form of insurance, the high deductibles and stuff are unaffordable for people to still get anything done. Number three is people like my wife, who had a very affordable, nice policy, now are looking around 6 months at a time for health care insurance. And lastly is, instead of covering the 40 million uninsured that they said it would, it'll be lucky to reach half that with policies that most people consider inadequate. That's the reality of Obamacare. I'd just like to see if I'm right or I need a further update in my information.
Well, I can tell you don't have a strong feeling about this.
Pointing out the obvious, it's not a feeling. This
I don't mean to. Yeah, I understand. And you're right. So we had 9 million people enrolled the first time around. We're expecting another 9. That doesn't even reach half of the 40, and 2/3 of that 9 million is Medicaid. I think that's right. Depending on where you were positioned in terms of insurance, you had insurance, and now we're facing new problems of high deductibles and trying to find insurance. There's a whole population of patients, of course, that never had insurance, and now they have it. That is a problem that's still out there, how to manage the high deductibles. If you went back to the conservative groups in the 1990s, what they said is that high deductible piece, which was their model, which was my model, someone comes in with this HRAs and MSAs, this other piece that helps people accumulate funds, whether they come from the person or the employer, to help make those lower cost decisions. That still needs to be worked out. The high deductible piece is not going away because it satisfies Republicans, Democrats, employers' objective of getting a person's, quote, skin in the game. And of course, most of these policies of Obamacare, and I'm not sure what you mean by doctors opting out of Obamacare. I'm not sure what that means. Of course, you can participate in Medicare and, you know, be on network panels for other insurance companies, but you know, I think that is the opportunity for us and for employers, is to try to find that gap. And there's a tremendous amount of revision and retooling of this act that needs to take place.
Is there any evidence that young guys are moving into the system like they had hoped, that the guys who really don't need much insurance that would carry the burden? Is there any growth in that younger population, men and women, into Obamacare?
You know, it's a very good question. And of course, he's asking the question of, well, what about young, healthy people that don't absorb all these health care costs that help with the risk pooling concept?
Right.
And what they're finding is in states like Maryland and Colorado, where people have a greater degree of education, the younger people are indeed moving into these policies. But in the Deep South, where they either can't afford it or they don't understand it, they're not.
Let's get one more question, and go ahead.
Yes. In Louisiana, it seems we're very slow moving towards ACOs. And how do physicians get involved in ACOs?
Well, I think you come together as a group, and I think geographically, I'll give you an example. I never thought I'd see an ACO in Mississippi until a group of primary care doctors in Oxford get together with an insurance company, in this case Aetna, and they say, we're going to form an ACO. It's going to be an ACO for employers, an ACO for Medicaid, it's going to be an ACO for Medicare. And so they work with a payer to put in infrastructure. Then in our case in Tupelo, they send out invitations to every specialist and primary care doctor in North Mississippi. And the primary care doctors are told, you can join us for free, and the specialists say, pay $50, you can join our organization too. Now, I'm not saying it's the right way to do it, but it wasn't real hard. But it did take a professional player in Aetna with that kind of experience to partner with physicians to get it done. But it takes a group of doctors who are interested in this to start with. And, you know, I'd encourage every local medical society to begin to explore these things. Because the clinically integrated network and the ACO, whatever you call it, are here to stay. And in our area in Tupelo, there's a lot of doctors that want to be a part of it. So,
Mark, thank you so much. Let's give him a hand. And I'm sure he'll be around for a few minutes.